Good afternoon, everyone. Welcome to the Sam Regenstrief Distinguished Lecturers Series. I think this might be our last SAM talk of the year. And we are very delighted to have a guest that was invited by the IU Center for Aging Research here at Regenstrief. And we are just thrilled to have Dr. Donovan Maust join us today. Actually, he drove down yesterday and has been meeting with people yesterday afternoon and today, and we really appreciate his flexibility and willingness to brave the weather and join us for these few days in Indiana. I think we promised you last night at dinner that this was the best weather and the best time to come to Indiana, and I was thinking about that this morning when we were experiencing that torrential downpour, so our apologies for that. You won't get to see the benefits of all that rain. So Dr. Maust is an associate professor of psychiatry at the University of Michigan Medical School and a research scientist with the Center for Clinical Management Research, the VA Ann Arbor Healthcare System. Dr. Maust is a board-certified geriatric psychiatrist and health services researcher. His research focuses on understanding determinants and outcomes of potentially inappropriate psychotropic prescribing to older adults, with particular interest in benzodiazepines, antipsychotics, and psychotropic/opioid polypharmacy in both the outpatient and long-term care settings. His other area of interest is in understanding how caregivers of people living with dementia shape how the person with dementia interacts with the healthcare system. Dr. Maust earned his medical degree from Johns Hopkins University and completed his training in psychiatry and geriatric psychiatry at the University of Pennsylvania. So welcome, Donovan.
Thank you very much for the introduction and for the invitation. I made the mistake of looking online to see who some of the previous speakers have been, and that really flared my imposter syndrome. So I appreciate you all being here and listening to me speak today. So I'm going to spend the bulk of the time talking about this thing called the National Dementia Workforce Study that has really consumed my life for the past year and a half. But I figured maybe you all might humor me, and I have a few slides at the beginning just to kind of explain how it is that a geriatric psychiatrist ended up being involved in and helping lead the study. So here are some disclosure slides. This one is for you all, and then this one is for me. And so here are the objectives. It's always sort of funny when you go back through your email chain and say, what did I tell them that I was going to talk about? And then you make the slides and you're like, well, I kind of talked about that. So anyways, here's hopefully what we'll cover over the next 45 minutes or so. So like I said, a few slides to start with on how it is that I ended up being involved in this study. So I did my residency and fellowship at the University of Pennsylvania. And there's this thing in Pennsylvania called the PACE program, and it's not what, say, Kathleen is thinking about, a PACE program. It's the Pharmaceutical Assistance Contract for the Elderly, so it's a low-income, it's a prescription drug assistance program that existed before Part D to help low-income older adults buy their medications. And so what I imagine kind of the thought bubble coming out of Harrisburg, the state capital, is why are we paying for prescriptions for these psychotropic meds, including benzos for older adults? Is that like really a good thing that the state wants to be paying for? And then maybe the unspoken idea was like, what if these folks fall and break a hip and they end up in the hospital or the nursing home, and think about the state and the cost that that's going to incur for the state. And this is when I was a resident, again, a psychiatry resident at Penn. So I was really thinking about how you prescribe medications to older adults. So the idea that out in the community, this prescribing is not being done by people who are seeing a psychiatrist was kind of like a new concept for me to realize and appreciate. So at Penn, I worked with a guy named David Oslin, who is also a geriatric psychiatrist. He runs behavioral health for the Philly VA. And he started this thing called the Behavioral Health Laboratory, which really is kind of like a triage and screening, a mental health triage and screening service for primary care clinicians. So they essentially could get a referral for their patients. It's telephone-based. This is pre-COVID. It was still telephone-based, which patients liked because someone was just calling them and taking them through a bunch of screening instruments. And so basically we sort of combined, or Dave basically combined the PACE program and this behavioral health laboratory to say, like, what can we learn about these older adults across the state who are getting prescribed a bunch of new psychotropic medications? And so we had a sample of over 400 older adults who had an average age of close to 80 years old, which is an unusually old sample of community dwelling older adults. And so what we found, here's a table, I'll have you focus on the right side. So these are about 250 adults, 249 who were newly prescribed an antidepressant that we talked to by phone about 2 weeks after we spoke to them. So I put their PHQ score 9, so a depression severity scale, with that red line is a cutoff of 10 or higher, which is a screening cutoff for major depressive disorder. And you can see that of older adults, almost 80 years old, newly prescribed an antidepressant, something like 15% of them met the screening criteria for major depression. And then across all of the different screening instruments that we gave these folks, something close to half of them didn't meet screening criteria for anything. Generalized anxiety, panic disorder, insomnia, nothing. And so for me, again, as a psychiatry resident, this was a real eye-opener to kind of think about how are these medications prescribed to older adults, and the fact that they're not being prescribed by psychiatrists, they're really not being prescribed by geriatric psychiatrists. So I really kind of had to think about my patients and my conditions that I would normally be seeing out in the wild. They're not seeing people like me. The other thing that's kind of funny about this paper that I published in 2011 is a familiar name in the list of authors and the works that I cited. So, several years before I ever met Kathleen, I was citing her. Okay, so more interest in prescribing. I've done a fair bit of work around benzo prescribing. So this is using the Part D public use file. You may or may not know, but every year CMS releases a public use file of medications prescribed to Part D, beneficiaries with Part D, and it includes your NPI. So I actually looked up my department chair to see, how many psychotropic meds he prescribes. And so we identified primary care physicians, and I was curious in the intensity of benzo prescribing and what are the factors associated with we defined intensity as all Part D days described in the denominator, and the top of it are benzo days specifically. And you can see those dark red counties are the top quartile of benzo prescribing. So there's just a lot of benzos out of all the medications being prescribed. And then we looked at individual clinicians to say what factors predict whether or not you're a high intensity benzo prescriber. And if you prescribe a lot of opioids, if you prescribe a lot of antibiotics, and then if you're a man, you're more likely to be a high intensity benzo prescriber. And so I've kind of had a long interest in the clinician level determinants of the care that people receive. And so one way to explore this a little bit more is just to ask clinicians. And so we followed that paper up with this paper. The results here really aren't interesting. This is more of a proof of concept where we actually used the Part D, Medicare Part D prescription information to develop a sample frame of clinicians that then we sent a survey to about their benzo prescribing. It was a tiny sample, only 100 clinicians, but to our knowledge, we're actually the first people that did this, where we used Medicare data to identify a practice of interest and then reached out to those clinicians. So CMS, you never ever can use CMS data to reach out to a beneficiary. That's the primary rule you cannot violate. But clinicians, CMS kind of doesn't care. To be clear, we had approval to do this study. So just demonstrating that this was a method that you could do. So a type of prescribing that I really have gotten interested in is specifically central nervous system active polypharmacy to patients with dementia. So the Beers criteria of the American Geriatric Society defines that as overlapping exposure to I have the medication classes listed here. Basically, psychotropic and opioid prescribing is not a great idea for older adults. Because of my work around antipsychotics, there's been this relentless drive to reduce antipsychotic prescribing to older adults with dementia in particular. And sort of my concern with this is that then there's other types of, you get sort of polypharmacy mishmash, polypharmacy potpourri prescribing because people are trying to avoid antipsychotics. And so we wanted to look at what's happening with prescribing to older adults with dementia. We use this was for an R01. We had a cohort of basically all Medicare beneficiaries in fee-for-service with Part D coverage who had dementia. So everybody with dementia in fee-for-service with Part D. And we found that 14% of these folks met our definition of polypharmacy, which was more than 30 days. So you couldn't just have one prescription for Zoloft. You had to have a refill for your 30-day supply of Zoloft. So more than 30 days of overlapping exposure of 3 or more medications, psychotropic or opioids. And it's not a transient thing. So about 60% had this polypharmacy for half the year or more. If we looked at the number of unique medications, 30% were prescribed overlapping exposure of 5 or more opioid and psychotropic medications. And then this is kind of the list of the top contributing medications to this polypharmacy. So this, taking kind of that benzo survey that we did, plus these very interesting findings about psychotropic and opioid polypharmacy, I spent the Christmas of COVID basically before everybody was getting vaccinated and we couldn't go to see family, basically wrote a grant to do work in Part D data to identify this type of polypharmacy. And then we were going to identify the clinicians contributing to it. And then we were going to survey them to try to understand how and why this prescribing is happening. So that grant started in April of 2022. And then about 6 months later, my colleague Steve Marcus at Penn sent me a 1-sentence email, 2-sentence email saying, you're already doing this. You're doing a survey of clinicians. You can just get a little bit money and do a bigger survey. And so here we are at the National Dementia Workforce Study. So what this RFA was released in the summer of 2022. It was written by a health economist. And so there's lots of language in there about we've learned about the demand side of healthcare, the characteristics of patients and of their caregivers that lead to the care that they receive. But what about the supply side, the workforce that actually delivers care to PLWD or persons living with dementia? And so what this RFA called for was an $81 million cooperative agreement with the National Institute on Aging to create a data resource for researchers. And I put that in blue and in bold, or green, blue. My daughters would make fun of me. Highlighting that these are not research aims that we propose to do with this data. This is really a data resource, a data infrastructure that we're creating for other researchers. That started in September 30 of 2023. I also put an asterisk there because the RFA said it would start in December, and several members of the study team made plans around having their fall free to take care of other things. And then as a surprise during Just in Time, we found out that it actually needed to be funded before the end of the federal fiscal year. So it started on September the 30th. For a national survey to be linked with patient outcomes, a survey of providers, which was really very broadly written. And so part of our challenge was thinking about, well, what is a dementia care provider? How do you define who that should be? What types of occupations we should include? And then linking it with patient outcomes and other administrative data. So again, like what we did with that survey of clinicians and the benzo prescribing is it's one thing to ask a clinician about how they prescribe a medication. It's another thing to ask them and then actually have the objective data from Medicare claims about how they actually prescribe the medication. And so that data linkage capacity was really important for this work. And then finally, again, this is a data infrastructure, so that its success will be measured in the extent to which researchers are using the data. And so it included a requirement for a pilot studies core to help accelerate the use of the data. And then this is all in service of the sort of growing research implementation milestones that NIA has developed around dementia-related research. And there's, I think, a relatively new milestone that's specifically focused on the dementia care workforce. And this is more, this is probably preaching to the choir here, but we know that the number of Americans with dementia is going to double to triple over the next couple of decades. This will be an enormous challenge for our healthcare system and really our society to help provide these adults the care that they need. We know that their healthcare costs and use are higher than other older adults. And there's just an enormous workforce that serves this population. And in particular, the direct care workforce, which by far is the largest part of this workforce. Dementia in particular, so people think about it as a condition that affects memory, but sort of defining feature is it impairs function, your ability to take care of and navigate daily life, cooking, writing checks, doing your laundry, more basic functional activities like getting dressed, bathing yourself, toileting yourself. Those are the types of care and help that patients with dementia need. And that's a critically important part of the workforce specifically for these individuals with dementia that we don't know a lot about. So ultimately, the goal of the RFA and the work that we're trying to do is to help us really understand who are these people who are providing care for these aging Americans. So in the fall of 2022, sort of this team was assembling. So my MPI is Joanne Spetz, who's a health economist at UCSF, who's just been an incredible collaborator. She's really an international leader in workforce research and specifically in the nursing workforce. James Wagner is a survey methodologist at the University of Michigan. Laura Wagner is they are of no relation, I will note. She is a geriatric nurse PhD who works at UCSF and does her clinical practices in the long-term care setting. And then Steve Marcus, my longtime friend and collaborator who sent me this RFA, and really I blame all of this on him. We have a huge study team, really remarkable study team, and the data collection is being done by RTI and DLH on the surveys. So like I said a couple slides ago, part of the challenge with this thing was thinking about who did we want to survey and how did we want to build this thing? And so we started with the community clinician survey. Like 20 years ago, this would have been called the physician survey, but that is actually not who's delivering care. So it's physicians, it's nurse practitioners, and physician assistants. These are primarily folks who are in outpatient ambulatory care, but this is also where we pick up people who are working in residential care settings. And then we thought about the types of settings where people with dementia are and decided to focus on the nursing home, assisted living communities, and then home care / home health. And then within those three kind of organizational surveys, there's both the survey that the staff complete, but then there's also like a single survey completed by an administrator to provide some information about the sort of structure and characteristics of the organization. And within those three organizational surveys, we focused on the licensed nursing workforce and direct care workers, so medical assistants, personal care aides. So after reading those high-level bullets, you might say, but Donovan, there's like all kinds of settings that aren't included there. There's all kinds of important members of the workforce, like social workers and physical therapists and occupational therapists. And I would say, yes, you are right. That is absolutely right. But we had to draw some boundaries around this thing for where we were going to start it and where we were going to launch it. And so these were the boundaries that we started with the proposal for over 70,000 surveys over the 5 years of this thing. So it's big. So in the fall of 2023, when this thing got started up, but before we had sort of all the data use agreements and everything in place to really get into the data and start working to develop our sample frames, that polypharmacy paper that I described, I had that data from my R01. And so we said, well, we can do some sort of exploratory work using that Medicare data to get a kind of lay of the land for who are the clinicians who are caring for these, what types of specialties should we be focusing on. And so at a very high level, what we did is we took fee-for-service data on Medicare beneficiaries with dementia. We limited it, limited it to dementia and the services that they got in 2019. And then we specifically looked in the Medicare carrier file, which is where professional billing services live. And what we wanted to do is really focus on that second bullet. So what types of clinicians are providing care to patients with dementia? And so just a couple things to point out. So this is about 2 million persons living with dementia who were in this data in 2019. They see an enormous number of clinicians. So 3/4 of them saw 5 or more. The median number of unique clinicians an individual patient saw was 8, with a quartile range. So 25th percentile to 75th percentile went up to 14. But that means that 1/4 of them saw more than 14 clinicians. We grouped it by setting at the bottom, so outpatient, residential, inpatient, other. You can see that that purple bar is 5+ clinicians. So in 4 out of 5 settings, the most common number of clinicians was 5 or more. Very, very few of these folks see a geriatric subspecialist physician. So geriatric medicine, geriatric psychiatry, or cognitive behavioral neurology, 13.6%. For me as a geriatric psychiatrist, only 1.7 of all Americans with dementia diagnosed in fee-for-service Medicare saw a geriatric psychiatrist. Out of all of the clinicians that care for persons with dementia, these geriatric subspecialists comprise just 0.5%. So I just think that's like a very sort of important piece of perspective to have when we think about the workforce caring for these adults. Overwhelmingly, they're provided care by primary care physicians, by nurse practitioners, and by PAs. And then we looked at other individual specialties of interest and some surprises. For example, 29% of persons with dementia have seen a podiatrist. So anyways, we went through specialty by specialty, but ultimately we ended up deciding to settle for the survey purposes. We focused on 3 groups of physicians: primary care physicians, psychiatrists, and neurologists, 2 groups of nurse practitioners, primary care nurse practitioners, and mental health nurse practitioners, and then physician assistants. Unfortunately, in the CMS data, the way that the classification works in CMS data for physician assistants, sort of the best you can do is there are surgical physician assistants, and we didn't include them. And then there's medical physician assistants, and so that's our PA group. Okay, so that was the first bullet up there. And the way that we built the sample frame for our community clinician survey is we basically used Medicare data and identified the beneficiaries with dementia using the claims data. There's all kinds of caveats around using Medicare data to identify patients with dementia. The goal of this is not to precisely and accurately identify every beneficiary with dementia in the United States, because Medicare data would fail at doing that. We just want to know with a reasonable likelihood who are the clinicians who are seeing patients with dementia. And so we use Medicare claims to identify those folks. We also looked at prescribing. So once we identified the beneficiaries with dementia, then we looked at all of their billing information to say, who are the billing clinicians for these encounters? And then we know in particular, in outpatient care, you get reimbursed more if it's an office visit with a physician than you do if it's with a nurse practitioner or a PA. And so you can miss people who really are actually the primary care clinician, but they're not in the outpatient bill. So we also looked at the Part D prescribing. Who are the prescribers to these beneficiaries with dementia, so that we could pick up these NPs and PAs. And that's it. So it's focused on these particular specialty groups of interest. And then we wanted to make sure we had good rural, urban representation of our sample frame. We wanted to make sure we had a good distribution of panel size. So we looked at like what's the median panel size of patients with dementia and look at people who are above it and below it. And then we used, like what the guide model used for our sort of marker of socioeconomic status, we used a combination of their panel size with who were enrolled in Medicaid and or eligible for the Part D low income subsidy. Our staff survey, so that's the easy survey. Our staff surveys are more complicated because of the sampling process and design that we had, where we started with the organization first. And for each of the 3 surveys, so for nursing home surveys, we just used the CMS list of who's a certified nursing facility. For assisted living communities, we went out to the states and got lists of licensed facilities from each state. And then in the first year, because of bandwidth, we limited our sample to not quite half of the states in the first year. And then in home care agencies, this one is tricky because there's both home health and there's home care, and some agencies provide both of those services, or they only provide one or the other. Home health being like Medicare reimbursed, say if you need like antibiotics at home or some type of a nursing service at home. So we used a CMS list of certified agencies, which are predominantly home health. Obviously, if they're certified with CMS, they're a home health agency, but some of them may also provide home care services. So we asked that when we first started working with them. And then in year 2, we're kind of recreating what we did with assisted living, where we're getting registered lists of agencies from all of the states. So where it gets tricky is we first have to sort of secure participation of the organization. And what that means for them is that there's the administrator survey to complete, but then they provide us a roster of staff in their organization, because what would not work and what would make my survey methodologist very unhappy would be if the organization said, here's a list of 10 people, you should talk to them, because that's not going to represent who is the typical worker in this agency if you have the organization picking the staff. And so we thought to really have a representative survey, we thought it was important for us to be able to do the sampling. For them, we provided them a list of sort of eligible job roles and titles. We asked them to tell us who are your staff in these roles and titles. And then we, on our end, sampled potential survey respondents from that roster of staff. So you could imagine, because also to protect the privacy of the staff, you can't have their employer knowing that they're participating in the survey. And understandably, there were some organizations that were reluctant to like hand over contact information about their staff. And so this just greatly complicated the staff survey, but we thought it was an important process and the right process to truly get a representative snapshot of this workforce. Important points I didn't mention is the community clinician survey. The incentive for that one is $250. For the staff survey, the organization gets an incentive of $2,000 where they're able to accept it. And then the individual staff participants receive a $100 incentive for participating in the survey that was designed to be in the sort of 20 to 30 minute duration. So for building the sample frame for each of these surveys, we tried to be relatively consistent, where that top row is sort of the size of the organization, so small versus large, the geography, urban versus rural. We had to oversample rural clinicians and organizations in order to get enough of them in the survey. Some type of a marker of socioeconomic status. And then those are sort of the most important common characteristics across all 4 of the surveys. So the questionnaires, thankfully, this is really Joanne's wheelhouse, and she took the lead on this part. Really, we had 7 questionnaires because we had the community clinician survey, the 3 staff surveys, and then we needed the organizational survey for the nursing home, assisted living, and home care. those kind of three, we tried to keep as consistent as we could across all of them, but some of them just needed some wording tweaks to make them relevant to the specific, assisted living versus nursing home setting. So we did a big literature review. The RFA actually required us to do a call for survey content that if any of you were on our mailing list, you would have received it. And we also sent it out to various different professional societies and organizations to ask for input. We have a number of consultants on the project and also on big projects like this. In addition to having a program officer, we have a project scientist who's Priscilla Novak at the NIA. Cognitive testing of the questionnaires with people that would potentially be respondents, so direct care workers, nurses, physician assistants. So some tweaking and refining of the questionnaires, and then they all had to be translated into Spanish. The community clinician survey, we didn't, because to have licensure as a nurse practitioner, as a PA, as a physician, you have to pass various, board exams that are in English. And so that survey is only offered in English. Spanish was a very obvious choice for the staff surveys for translation. But then after Spanish, you get into like single digits of % for what's the kind of third place language that this workforce speaks. And it's very region and location specific. If you're in California versus if you're in Louisiana versus if you're in Texas. So we said we're going to start with Spanish, and then depending as we're recruiting, we'll consider adding other languages as we go. And these have all been available on the website since last summer. These are the high level kind of buckets of what's on the survey content with a couple example items. So in the community clinician survey, what type of cognitive assessment do you use in your practice? Who administers it? Is it you? Is it a nurse? Is it a psychologist? As part of your evaluation for cognitive impairment, what types of things do you routinely order? Under the staff survey, is it rewarding to work with people who have dementia? I'm comfortable touching people with dementia. Where there were existing instruments available, we tried to use those. And specifically for the staff surveys around dementia care, there are like a number of different options. We were really excited when there was like a 30 item instrument that had been condensed to like 6 items that had good psychometrics. We were really happy where people had done that work, and we could use that 6 item instrument. And then the administrator surveys sort of gets at like organizational structural questions that the staff wouldn't be expected to know the answer to. There's a lot of this type of information for the nursing home survey that's already available in publicly available data, but that is not true for assisted living or for the home health sort of segment. Just to give you a couple examples, so the vast majority of these surveys have been completed online, but we did have paper instruments as an additional way to offer for completion. So here are just some screenshots. This is from the community clinician survey asking questions about the types of like workup and evaluation and referrals you do for patients with suspected cognitive impairment. Here's an example from the assisted living staff survey. That are essentially getting at the sort of the environment, their practice environment, communication challenges in their practice environment. And then this set of items is basically identical to what you would also find in the nursing home staff survey or in the home care survey. This survey is the home health survey. It looks a little bit different because this is the survey that's done by DLH. And the previous 2 that I showed you were from RTI. And this is an example of the administrator survey that asks questions about benefits, paid time off, sick time, and then specific formal training, specific formal continuing education that the organization offers. So data, the whole point of this thing is to collect the data and then to make it available. And we are hurtling towards, so fielding of wave 1 ended at the end of February, or was it the end of March? It's all a blur. And we're hurtling towards data release, which we've very publicly said will be July the 1st. And we can't take that back. So there will be two versions of survey data available. Public use files, so where we really want the surveys as a standalone thing to be useful. There's this thing called NACDA, which is NIA supported, the National Archive of Computerized Data on Aging, where you just need to register, and really anyone can register as a user, and the public use versions will be available for download there. Because the wave one, year one sample of the organizational surveys is relatively small, we will not have the administrator surveys available as part of the public release data. But there are some variables from that administrator survey that would potentially be useful, such as like ownership type. So there's a small handful of those variables from the administrator survey that will be available on the staff public use surveys from those organizations. The other challenge with this is the importance of protecting respondent identity. And so they're what are called indirect identifiers, where if you know somebody is a nurse practitioner who did training in mental health and they work in a small facility, essentially if you have enough kind of pieces of information about somebody, you can figure out who that person is. And so we're going through, we've identified those variables, those indirect identifiers in the survey to basically, if it's a continuous variable, like what year did you get your degree in, we collapse it rather than offer it as a continuous variable. And so essentially some tweaks to specific items in the public use file to make sure we're protecting respondent privacy. And then the next couple slides are gonna go through the linked data, and those will be available in what's called linkage. And so I'm just gonna try and go through this quickly. So again, a big part of the potential of this survey is the ability to link it to other data, to learn linking the administrator and staff surveys, linking the surveys to the environment, the local context that the organization is in, that the clinician is working in. And I'm gonna walk through these linked data quickly. You can read all about this on our website, specifically if you go to this data linkages page. So like I said, the most simple type of linked survey is that you can get the staff surveys without any of the de-identification stuff. So the surveys in linkage are the like pure unadulterated surveys. If you want to link those to the staff surveys, you can only do that in linkage. And then all of the surveys will go into linkage with state and county codes so that you can match with the area health resources files, which literally has like thousands of variables at the county level that are about like local healthcare supply, socioeconomic status, number of home health agencies, number of nursing home beds, huge amount of information. And then at the state level, we'll have the AARP long-term services and state scorecard, and then also a report from Mathematica that gets into Medicaid spending and like what's the balance that's on nursing home versus home and community-based services. Also, because the community clinician and the nursing home surveys were really built using the NPI of the clinician and the CCN, the CMS certification number of the nursing home, that allows you to match with all kinds of data. One thing I'm particularly excited about is these claims-based summary files that we're preparing. So the idea here is using raw Medicare, CMS claims and assessment data is very challenging, and a lot of people may not have the technical expertise around them to use those data, and it narrows the pool of researchers that can use that data. So there's this thing called LTC Focus that comes out of Brown University and Vince Moore's shop, where they basically use MDS data and have an incredibly rich data source at the nursing home facility level, where they've done all of the crunching of the MDS data, and it is in a really, really useful form for researchers to use the data. So we want to do something like that. And again, you can go to the website to read a little bit more. Here, that is way too small for you to read, but basically for participating clinicians, we will use the claims data to identify this is how many Medicare beneficiaries they see, this is how many of them have dementia, this is what their demographic characteristics are. this many of them have had a home health visit. This many of them have had a home health visit from the clinician who completed the survey. Noel, this is for you, a bunch of medication. So like out of this clinician's panel, this many patients got an antipsychotic. They received this many total days of antipsychotic, also doing antibiotics, highly anticholinergic medications, a number of different drug classes. So trying to make these data really accessible for researchers to be able to use. And then there's all kinds of other CMS data like the payroll-based journal data, nursing home compare, and LTC focus that because you have the CCN and we have the CCN of our participating facilities in linkage, all of that can be linked to the survey data. And then finally, the reason that the linkage platform was set up was for NIA-funded studies to be able to link to beneficiary level CMS data about the study participants. And so what that means is that you can get beneficiary level CMS data of the people cared for by our survey respondents. So for the community clinician survey, basically in linkage, they have the NPIs of all of the clinicians that were in our sample frame. You can use that to then identify all of the beneficiaries that those clinicians provided care for. And as a researcher, you can request all of that Medicare data about the patients that clinicians in our survey cared for. So all of those things we ask them about in the survey, you can get the Medicare data and actually see the care that their patients received. And importantly, it can be both beneficiaries with and without dementia. So if you want to compare care, how does it differ for patients with and without dementia, you can do that. Nursing home survey works the same way. We, in linkage, we provided them the CCNs of all of the participating facilities. When you have that, you can then identify through MDS assessments, everyone that received care in that facility. And then because you know that, you can get all of their Medicare and their Medicaid data. So the data will be available from 2015 up until whatever is the most recent available. There will likely be some kinks here because potentially some of these data files, depending on what the researcher asks for, could be very large. And so we're waiting for linkage to tell us that we're like using too much space, but we'll worry about that when it happens. And then in the home stretch here, we're very excited about adding qualitative data. So this was in the original proposal. There was a couple year hiatus where we weren't sure if it could happen or not, but it is going to happen where we're gonna, hopefully starting with data collection in year 3, we will identify a subset of our survey respondents that then agree to participate in a semi-structured interview. Again, this will all be publicly available. We're working with a new sort of somebody being brought onto the team who has expertise in sort of big data approaches to qualitative data for tagging the interviews with sort of topics and keywords of interest so that like we're thinking this will be a qualitative data source on the order of like 1,000 interviews across all of the surveys. That's obviously you can't go through transcripts for all of those. So the goal is to use this big data approach to tag transcripts with concepts and items of interest. So the data summary, public use files available on NACDA, the restricted use files, so any type of linkage you want to do with the survey data, any linked data can only happen on the linkage platform. They will be available this summer from the first wave, and it's all free, in particular for the CMS data that hopefully should be very appealing because CMS data otherwise can be very expensive to use. Okay, so I'm in the last couple slides, I promise. The slide after this is going to show you the sample size. I'm starting with this one just as a disclaimer. So we proposed this top, not a pointer, maybe. Oh, no, I didn't want to do that. Where'd you go? Come back. There we go. Okay. The top is what we proposed in the proposal where we would do community clinician survey in year 1, nursing home and home care in year 2, and then get to assisted living in year 3 with pilot awards starting in year 3. A very approach to be reasonable and thoughtful and to allow really careful planning of the rollout of this project. in working with our NIA counterpart during Just in Time in the summer of 2023, it is a cooperative agreement, but there was not so much cooperation as we were instructed that our new timeline would be the bottom timeline with rollout of all of the surveys in the first year. And so this did not allow the sort of careful and thoughtful rollout of these surveys in the way that we wanted. And so this is where we ended up with data collection. So the community clinician sample was 25,000 clinicians. We're just a bit under 20% response rate for the first year. Happily, when we look at the sampling characteristics, there aren't actually significant differences in, like, it's not like clinicians with big panels of dementia patients responded and everybody else ignored us. So there aren't clear differences in who did or didn't respond. Unfortunately, James's expertise is in non-response bias in surveys. So where our bases are covered there. The way the sample frame was developed, by the time we needed to have the Wave 2 sample ready to go, we couldn't have been able to update the community clinician sample frame. And so for the data collection, the Wave 2 data collection, which basically is starting now, we are continuing to go after the non-responders in that first wave, including increasing the incentive further and also having a shortened instrument where we sort of kept what we think are the most important high yield items and got rid of some of the other stuff. So we can, we'll build on that community clinician sample. Nursing home, assisted living, and home care, the sample was 200 organizations with the hope that we would get 100 organizations. You can see that we did not meet those goals. Nursing home and assisted living, once we got the organization to agree, we actually had very good response rates from the staff on the order of like 60 to even 70% of staff respondents who did respond. So we ended up with decent numbers of respondents for the staff surveys in nursing home and assisted living. So for Wave 2, for those, we have greatly increased the sample. I think we thought it would be a sample of like 600 each, and we've increased that to 1,000 each. So we're closer to what our target sample is for year 2. Home care was incredibly hard. And when we, working with the data collection organization, you know, the first step is to like, okay, here's this list of agencies we got from CMS, and they would, you know, go to Google, go to wherever to try to track down these organizations. And a lot of times the address would be like a PO box. If you went on Google Maps, the location for the business literally would be like a storefront in a strip mall. We had by far the most where we did try to get a hold of the organization and the agency, and it no longer existed because they had gone out of business. And so it really reflects the sort of transient, high churn nature of that work. We had our data monitoring committee meeting with the NIA in January, and I think we were all like really worried about what the response would be given the response to that survey. And that's the one that they are the most engaged in. They want us to succeed on that one more than any other one, I think, because there is so little data there. And essentially the take home was like, try whatever you can, do whatever you can. And so we have lots of options that we're going through to hopefully. So in year 1, we're actually not releasing the home care data because it is too small. Our hope is that maybe by year 4 or 5, we will have that survey in a place where we really want it to be. Certainly releasing data before then, but having a big, robust survey like everyone wants is going to take us a couple years to get there. So I'll just end with a couple acknowledgements. First, staff team, the folks hired for NDWS have been exceptional. And then my own personal research staff team who have like kept everything going while I've been very distracted. It would all fall apart without them. And then I, have the privilege of working with incredibly great collaborators and having had NIA funding, which I hope will continue. And then my wonderful family, my wife and daughters, and I will stop here. website is in the middle. And then we currently are accepting, where our call for survey items is open, including for our semi-structured interviews that are going to happen in year 3. If you have domains that you would really like us to ask, we're also accepting suggestions for what those interviews will include. And with that, I'll stop. Thank you all. Nice catch.
Then I'm curious about how formally you guys as a project team are tracking and working towards.
I think it's safe to, so I would say the most important metric to NIA is that these data are getting used. I think like full stop, they want the data to be used. Papers are good, but really it would be people using these data and getting grants. Like I think obviously the goal, I mean, hopefully obviously the goal for everyone is to actually like have an impact. And if there's a finding that like nursing home, you know, a finding that's really associated with turnover that nursing homes can actually use to help lower turnover, that is the fundamental goal. You know, if they're just differentially provided care to patients based on, say, particular characteristics that these data might help inform particular patients that are being left out. That is all very important, but I think the easy thing to measure from the NIA's perspective are papers. Like, you know, John Phillips, our PO, has even mentioned, like with HRS or with NHATS, if you go to PubMed and you look at like publications using the data or citing the grant and what that curve looks like they want to see papers in PubMed using these data. And then ultimately, I think for NIA, it's very important to show that this is leading to work that is advancing that milestone, like the 13J care workforce milestone. Yeah.
Oh, Susan, can I go next? Okay. Thanks, Donovan. This is a really mammoth project, and it's really kind of cool to see where it's gone from the RFA that I remember reading to where it is now. And I know that obviously when you're responding to an RFA, there's specific things that you include because they've asked you to. And then I was particularly interested in when you talked about the sort of specificity as you go down from provider, right? Like, you know, physician and then down to like assisted living and how that can vary by state, you know, based on licensure and, you know, scope of practice. What about sort of the gray zone around home and community-based workers, and even something I think about like Dementia Friendly America, that like has a specific curriculum that in some states like Indiana, you know, is pretty robust, where they've really tried to kind of infiltrate, you know, and some things obviously wouldn't be within your purview because they're not working directly with people. It's like maybe just bank tellers and that kind of thing. But then there is sort of this workforce that maybe isn't recognized as being sort of healthcare, but has a significant interface, you know, with people living with cognitive impairment. And I'm curious, like conceptually, like how does this work? You know, how could it basically, you know, be a step to the next, or and what you think about that?
Yeah, that's a great question. I'm gonna start and answer even an earlier question than that. Is even within the healthcare workforce, getting people to pay attention and answer. So like the clinicians, like what is dementia care and who provides dementia care and how do you define that? And the idea that like I think probably there are actually plenty of primary clinicians who wouldn't necessarily think of themselves as providing care for dementia. But I'm like, no, but if you care for older adults in the United States, you are caring for people who have dementia, whether or not you recognize it. And we want those people to be in the survey. And one of the things that we're kind of excited about is one of the survey items asks the clinicians, like, what proportion of your panel do you think has dementia? And then to actually look in the claims data and at least see what proportion we know of the people that they cared for have a dementia diagnosis in their claims. For home care agencies, on the initial phone call, having agencies be like, oh no, we don't do dementia. It's like, well, but do you care for older adults? Oh yeah, we do that. Well, okay, we want you to participate. And so even within healthcare, thinking and tweaking our language to make sure we're really getting the people that we want. And even still within healthcare, there's just a huge gap around social workers and say role of care navigators, particularly sort of in outpatient settings, the rehab specialists. Like I really, Nicole, I think the answer is, I feel like there's so many people even within the healthcare setting that we haven't quite figured out the right way to get them. I want to kind of do what we're doing now right, and then expand that maybe even within healthcare a little bit more and do it right. And then think even maybe more broadly. The other reason with keeping it within healthcare is that we can track the outcomes. Because of the Medicare data, we can track the outcomes. And as you get into the blurrier area and different types of workforce, it's much harder to make the argument that anything that they're doing, you can then identify and detect in the claims data that we have.
Thank you. I'm curious, Donovan, if you could talk a little bit about the pilot program. And I know you had a really large response, and I'm sure there are people interested in thinking about this for your next cycle. If you want to share a little bit about the ones that were funded and what you're hoping for in the next round.
Yeah, thank you. Great. Thank you for asking that question. So we have, say, a robust pilot program that the RFA allowed us to go up to $100,000 in direct costs. So they're like significant pilot awards. In our first cycle, I think we had like 71 applications, so incredibly competitive. And we literally just had the meeting with them on Monday. And so first it was weird to do a pilot award thing when there's no data released yet. And we were like, we know that this is weird. This is what the NIA wanted us to do. So just bear with us and like come up with your best idea for what you can do. And at a meeting with them on Monday with the folks who were awarded, we were like, bear with us, you're our like data release guinea pigs. And so we can work together and make this better for everybody. And I am really embarrassed to say, I should know off the top of my head what the awarded pilots were. A couple, say there was one, the one that focused on the community clinician survey was specifically related to, there's a couple items related to deprescribing. And so they were going to look at how physicians answered, how clinicians answered that, and then look at some of the prescribing data. There was one that was around like in the staff surveys looking at intent to turnover, and a number of the projects were focused on turnover, and I really failed that part of the assignment to not be able to better explain what the other 6 were that were awarded. However, you can look on our website and all 6 are there. We just closed the second call for pilots. Again, had a really strong response, and I think my reviews are on my to-do list, and those are due the end of May for me. So those will be announced over the summer, and we'll have pilots every year. We'll hopefully fund in the order of 6 of them. Again, relatively, I think, generous awards for pilot work that are 12 to 18 months. And so would love to have folks apply. The other thing that was actually useful for us to offer those pilots early is the questions were very helpful for us to understand what people did or did not understand about what we were trying to do. And so we made a like frequently asked questions document that's on our website that hopefully is useful as people are starting to investigate and think about using the data. And again, with this data release this summer, I think we're just going to learn a ton, and it will really help us kind of update the guidance we have out there, ultimately to support the community of data users.
We have one final question from the online community? Were you able to verify that assisted living facilities who said they offered certain care actually provided that care to individuals?
So that's a good question, and I think the short answer is no. I'm not sure how we would do that other than like an inspection, which we definitely don't want to get into that business. So no, I think, just like any of the staff respondents, we are hoping that people are answering honestly. All right, thank you all.